All right, well, welcome to this general review on the coagulation cascade. I'm Dr. Bustai, your faculty for this lecture with High Yield Med Reviews. You know, the goal of lectures related to core clinical concepts is to help you, to ensure that you, as a clinician, have a good foundation on the pathophysiology of disease and how therapeutic interventions are applied to the patients that we have the privilege of serving. Now, to do that most effectively, a clinician should have knowledge about the normal within the context of clinical practice. Doing this helps clinicians bridge that gap between the knowledge acquisition and, more importantly, the application. Now, the following topic review will cover the basic processes in place that ultimately lead to a balance in clot or thrombus formation and its degradation in an effort to maintain the basics of coagulation as part of the body's main mechanism of homeostasis. With that perspective, let's dive into the details of the coagulation cascade and that thrombus formation. So there are a number of topics that we're going to address. I've tried to provide this outline to keep us on track, but also to give you guidance as we step through this complicated process. Now, some of you have been exposed to this depending on your level of training, and maybe it's been a while since you have dove into this concept, but I would like to revisit it and go into a few levels of detail really where it pertains to clinical disease and also the application of drug therapy that we will learn more about later on in other areas. So with that, let's start off with the big picture, okay? So I feel like it's important to start from the bird's eye perspective, and then we start to zoom in and get into detail and then back out and summarize it to help it put it all together, okay? All right, so the first thing that needs to be given consideration is the coagulation cascade requires functionally active clotting factors to be present, okay? You're going to see in a minute that there is a cascade, almost like a domino effect, that one particular clotting factor then triggers the activation of another clotting factor and on until we develop these fibrin monomers that form the basic structure of a clot, especially a venous thromboembolic event type of clot, okay? So in order for that to happen, you need to understand how clotting factors are not only made, but also functionally activated. And I know that that maybe seems a little minute in its detail there, but the body can make clotting factors, i.e. mainly from the liver, okay, and that's usually what's over here. They're called typically vitamin K dependent clotting factors, and we traditionally think of them as 2, 7, 9, and 10, but also protein C and S. And so the liver has the ability to make these clotting factors, but they're in a non-activated state. So while they're there, they don't do much, okay? So they have to get functionally activated. And that the way they get functionally activated over to this side, okay, is to get carboxylated. And just like with a lot of chemical reactions, it's not important that you remember every single detail and every enzymatic reaction. However, it does play an important part when you want to understand drug therapy, okay? But gamma glutamyl carboxylase is necessary for that activation process. It also requires the presence of something called reduced vitamin K. So vitamin K, being a vitamin, right? I mean, the names help us a little bit here. There's two states that it kind of exists in an oxidized and in a reduced state. So in the reduced state, gamma glutamyl carboxylase utilizes it in order to carboxylate the clotting factor. And you're like, oh my goodness, Dr. Bustai, this is getting into some biochemistry, chemistry, and things I just don't care about. I understand that, but if you keep following me, it does make a little bit of sense and why it matters, okay? I will bring it together for you. But once you functionally activate a clotting factor, then that vitamin K is in its oxidized state, and it must now be put back into a reduced state. And there's another enzyme called vitamin K 2,3-epoxide reductase. Okay. Now, again, reductase, it's reducing the oxidized form to the reduced form. So, I mean, the name is at least helping you. No different than gamma glutamyl carboxylase is carboxylating, right? Adding a CO2 to the structure. And that is necessary in order for it to work. All right, so that is the basics, very basic high level, okay, of the clotting factors. Now I'm going to come back to that, and we're going to dive into what does that carboxylation mean, and the so what, who cares, okay? But you see that warfarin, which is an anticoagulant, one of our vitamin K antagonists, interrupts that process. And so that's one of our therapeutic interventions if we want to disrupt the functional activation of clotting factors. Now, these clotting factors, as I said, feed into a coagulation cascade, kind of like in a domino format, right? And one thing leads to another, a chain reaction until you get to the end product. But it's not just about the coagulation cascade. There is another system that's also going on in the body, and that's platelet activation and aggregation. So when we think about a thrombus or thrombosis that's occurring in the vasculature, we have different types of thrombosis, which I'll discuss towards the end here. One side that is arterial thrombosis, and then there's the venous side or venous thrombosis. There's both thrombi and thrombus that can form, but they are made up of different components, or the percent of composition of components differ between the two. All right, again, just high level, I'm going to come back to it. But it's important to recognize that the coagulation cascade, which is largely seen on this side right here, okay? This side over here on the left is the coagulation cascade, and you see that there are even two subdivisions. There's the extrinsic pathway, and then there's the intrinsic pathway, and those are identified over here on kind of the side, or which side turns on and feeds the rest of the pathway. But you can see they both merge at factor 10A. Okay, they merge regardless of which side. But that's the coagulation cascade side. Then over here you see again the platelets. And again, they have to get activated. That kind of prepares them to aggregate and to facilitate part of that thrombus or clot formation. So you can see that the activated platelets feed down, and we have a clot that's forming. And a clot will eventually break itself down. So our bodies are constantly in this, preventing us from bleeding to death, but also preventing us from clotting to death. There's the back and the forth, and that's what the vascular hemostasis that's going on to help us in that. Now, when one side gets more effect, or sometimes our genetic predispositions tip the scale that favor bleeding or clotting, starts to influence the way we see and manifest a disease and how we're going to treat it, okay? And again, I will bring that back at the end and try to summarize it, but it becomes important that you understand these steps in this larger picture and process, because not only do we have therapeutic interventions, but it also helps us to understand what the disease is, how it's happening, why it's happening, why is it causing a clot to form, and why is it causing or bleeding to be manifested. Sometimes it is a genetic underlying situation that gets tipped over by some external influence. So maybe somebody starts to smoke, or they start taking estrogen or something else that tips the scale that favors one direction over another, and it manifests it, right? I will give you just a quick clinical integration point here. For patients who get pregnant, the estrogen levels can go up and will go up with a healthy, otherwise normal pregnancy. There's nothing wrong with that, except that estrogen is known to increase the gene transcription and translation for the development of clotting factors. And if you have an underlying hypercoagulable disease that you don't know about, but all of a sudden get pregnant, that new variable or confounder in your environment or the milieu tips the scale that now triggers or exposes the underlying hypercoagulable disorder. It usually manifests in pregnancy as early miscarriage, because what ends up happening is the placenta gets infarcted because the clots that are forming are blocking the blood flow to the placenta, and eventually the developing fetus there and the baby basically don't get the blood flow and the nutrients it needs, and so the body basically aborts it, and that's a miscarriage. So when women have multiple back-to-back miscarriages without any obvious explanation for it, you need to think about a hypercoagulable disorder that is underlying in the background that maybe they just don't know about, right? So you ask if they have past medical history, they say, I don't, none, right? But that's where you may do further testing. That is the clue. That is the clinical integration piece that helps you when you understand the normal, the abnormal, or the situation that produces the abnormal then begins to make sense. Because remember, we at high yield care about that you learn to understand why you do what you do and why something is happening, not just memorize your way through life, because that will eventually fail you. So big picture, the coagulation cascade and platelet aggregation do come together. In fact, you can even see that the coagulation cascade at the level of thrombin turns on is one of many, it's not the only, but one of many contributors that activate platelets that prepare them for that aggregation. So their systems actually do cross over and they help each other. But think about it, if you're bleeding, you want that to happen. You need to form that clot to stop yourself from bleeding to death, okay? So I hope that, again, I'm just laying the groundwork. We're going to dive a little bit deeper into those components, but I hope that that just bird's eye perspective already started putting some pieces of the puzzle together for you, okay? The other thing that I want to point out before we move on is that you're going to see within the reactions, you know, all these clotting factors that are here, right? But then you also see cofactors. And you see something like calcium present. Calcium in part comes from the platelets. In the endovascular tissue in that area where that injury is occurring, calcium is being released from the activated platelets. That facilitates in part the propagation of the coagulation cascade. So calcium is necessary to be present. You also see these cofactors. For example, in these two areas here that I just highlighted, we have factor 8A and factor 5A. And so those are also regulatory points that the body uses to regulate the balance and how much fibrin monomer do we make to form a clot and how much do we turn it off to prevent that clot from forming. And we're going to see here that thrombin becomes a very important role in that process. It wears a lot of hats, thrombin. You can see that it's already turning on the platelets, okay? Well, guess what is a major target of drug therapy? The two clotting factors that are most involved in this process towards the end. Factor 10A, okay, factor 10A, and 2A, thrombin. So we have like a drug class called the direct thrombin inhibitors. We have another drug class called factor 10A inhibitors or direct 10A inhibitors for those reasons. So you're targeting important components of that larger cascade. Okay, big picture. You're like, hey, that was enough. I'm done. Well, stick with me because I do want to pull together a couple additional points and reinforce why thrombin is so important to so many aspects of this process. So with that, let's now jump into a little bit more detail going back to those clotting factors. Remember, we can produce them, but they have to get functionally activated. So how do we get this process to go like this? Well, that's that carboxylase. So that means we have to add on something to the chemical structure that allows it to be more functional. So it's present, but it's not fully functional yet. So what is carboxylation? Well, here's a little bit more detailed. And again, I don't want to cause a seizure or hopefully not PTSD in anybody who sees some of these chemical structures and like, I gave up chemistry a long time ago. Thank you, Dr. Bustai, but I don't want to go into it anymore. It's really actually fascinating if you understand why. But you can see here that we have one carboxyl group here on portion of the structure, but we need another one that's missing in this area. And so gamma glutamyl carboxylase needs that reduced vitamin K, okay? And you see that it adds that second carboxylase, or carboxyl group, sorry, onto the structure. And you see that there's also even some little charges that are present there. And those charges become very important. Again, not so much for medication and all this stuff, but just understanding physiology. Remember, charges like to interact with each other that are opposite. So you remember that calcium that I talked to you about or mentioned in the coagulation cascade, and that it's necessary in the environment for it to facilitate not only the conversion of some of these clotting factors to functional activated states, but also to help them to actually bind to the area that needs to stop bleeding, if you will. So that's what this is looking like. So if you see that we have the two carboxyl groups now here, they both have negative charges. Well, when you have a basement membrane of like the vasculature that gets injured, you expose underlying tissue. And that tissue, if you zoom in closer, is made up of sometimes proteins and other things. And those proteins also have charges. So, well, negative charges and other negative charges typically are not going to draw together. Those similar are going to oppose each other. They need a positive in the middle. And that's where you see the calcium sitting there kind of exerting that balance in the positive charges between the clotting factor and the basement membrane of that damaged endovascular lining, so that the clotting factor stays there to propagate the clot in that environment, but also to stay and anchor itself so that it can help to solidify that clot and prevent you from continuing to bleed. So to activate it, it has to work. Well, warfarin, the anticoagulant warfarin, which is a vitamin K antagonist, basically is going to prevent that from happening. And so when you lose that one there, that clotting factor kind of wobbles and doesn't stick very well to the area, so it doesn't work. So guess what? Your risk of bleeding goes up, right? And as a result, then the markers of coagulation, P, T, I, and R, are then going to increase as a result of that. Okay? So again, it's the why. I know you realize it's more detail, but it's just helping you to put it together that it matters that these molecules get activated and that drugs strategically interfere with them. And when you understand why, then it makes sense why you see changes in the coagulation markers and then increased risk of bleeding eventually in these patients, okay? Same thing when you give a direct thrombin inhibitor. If you take it straight out of the equation, right, you block that, then the propagation of the rest of the coagulation cascade is now going to be stopped or interrupted. Makes sense. You're not going to make those fibrin monomers. So you understand now the why, and then you don't have to memorize it as much. That becomes actually very relevant for board exams, because board exams are testing you on core concepts. And if you understand the core concept, you can answer any question given to you. People who memorize their way through clinical training and practice typically are not as good and apply information wrong in many cases. All right. Now, let's dive into thrombin. Okay, kind of think of it as kind of like the king of the coagulation cascade. It does a lot of things. It's also a kind of a selfish little pig, if you want to think about it. It propagates its own self. It's all about thrombin. It is its own cheerleader, if you will. Okay, So you're going to see here in a minute that it not only stimulates, activates, but it protects the clot that it's forming through a number of different steps. And then it also turns on those platelets, as we talked about. So I just want to make sure that you see those individual steps that are occurring and why the target against it by drug therapy is so important, why so many medications are geared towards interrupting it because of this, especially in acute events where you have acute thrombus formation, and that thrombotic event is high risk for embolizing or causing total vessel occlusion, which would then cause decreased blood flow distal to that point and cause ischemia and infarct. Like I gave you an example of unfortunate miscarriages in a context of a hypercoagulable disorder that the patient doesn't even know they have. All right, so let's dive into the first one, which is going to be about just general information. So thrombin is also known as factor 2, and it's specifically 2A. Prothrombin, okay, is the precursor to thrombin. So it's not difficult, but thrombin, the activated form, is the A that you see on the name, right? So it's activated factor 2, also known as thrombin. So regular factor 2 without the A is prothrombin. So just terminology alone is important that we understand what that means. But remember, thrombin plays a number of key roles. It can facilitate the autoactivation of itself, so it propagates its own concentration very rapidly, very early on, and in high concentrations. As that clot is forming, so it's generating lots of fibrin monomers, it is now then going to stabilize that clot, solidifying it. It's going to protect it from being broken down, and it will regulate itself at some point, but it's like after I do my part, right? And then it turns on those platelets. So it connects another system in the body that we have other drug therapy for as well, okay? So the first one is autoactivation. And so what you see in this diagram is, again, the coagulation cascade. And what I've provided over here on the right side is the list of the different roles, okay? So each of these next few diagrams will reflect those roles. And in the red line, you can see that there is a feedback that turns on and activates those cofactors, particularly that help generate factor 10A. Remember, that's where the common pathway really starts, whether it's from the extrinsic pathway or the intrinsic pathway. When we think about extrinsic pathways, you can see up here that you see the vascular injury. That's what causes initially, like if, I don't care what the injury was, trauma, surgical, you picked at something, whatever, and it starts to bleed. Well, you're going to release tissue factor along with some localized calcium, and that is what triggers the tissue factor 7A complex. Again, that drives from turning on 10 to 10A. But it also turns on, you can see that feeds into the intrinsic or the internal pathway, okay, from within, not an external stimuli. But you see up here it says vascular injury. Well, that vascular injury may be from a different insult, not something like traumatic. It could be from ischemia. It could be from inflammation, irritation, atherosclerotic plaque, all kinds of things, right? Those are internal vascular injuries or inflammation that can occur. But you see that thrombin, when it starts to get formed, it rapidly turns on itself. So that's that auto activation where the concentrations skyrocket initially and then it starts to come back down. So obviously too much of anything is bad. Even thrombin knows that. So it will regulate itself, and that's that protein C that we're going to come to in just a few minutes. But once thrombin is made here and in high concentrations, it's really driving the production of fibrin monomers. And those fibrin monomers have to start to connect. They kind of think of them as the concrete of a foundation for building a house. It's kind of like that. You need those fibrin monomers to collate and integrate and create crosslinks, okay, to stabilize the foundation. Remember, when they pour concrete, you don't just start putting building straight on it as immediately after you poured it. You have to let that concrete settle, harden, cure. Then you start to use it as a foundation. It's the same concept happening here in the coagulation cascade. So that leads us now to the next step, which is as these fibrin monomers are being made, they're going to be forming crosslinks. And that is that clot stabilization. So thrombin is protecting the very fibrin monomers it's laying down. Okay, no different than a construction worker is going to protect at some level by preventing the workers from preventing them from putting up the walls and other things until that concrete is cured. And the way it does that is it turns on and facilitates the activation of factor 13. And in that forms the crosslinks that start to allow those fibrin monomers to take shape and solidify. Okay? So autoactivation propagates itself, makes tons of fibrin monomers, and is stabilizing that foundation so that it can be built upon. As the red blood cells come in, as the platelets come in, we form this plug, right? And that's that scab, if you will, that helps to stop the bleeding or the injury from happening. Now, if it's going in the wrong direction, sometimes it can go too much, and then it's going to occlude the vessel, and then there's no distal flow through it. And that's why we intervene in conditions like acute coronary syndrome, i.e. STEMI, right? Pulmonary embolisms, DVTs, especially in patients with hypercoagulable disorders, okay? Okay, so that's stabilization. The next is, remember, once it's made this clot, it's going to protect it. It doesn't want it to be broken down. If you were to immediately start to use it, it might not be strong enough. No different if we don't let it cure, stabilize, then it's not going to be that hard surface that allows the rest of the things to be built on. So one of the things that it does is it increases the release of something called TAFI, thrombin activating fibrolysis inhibitor. So it's inhibiting fibrinolysis. Well, what is fibrinolysis? Well, remember, we make endogenous thrombolytics, if you will. Now, we administer thrombolytics, things like alteplase, retaplase, tenecteplase, and we use them in strokes and in STEMI in particular, maybe to declot a catheter or something. Well, that's turning on plasminogen to the active form of plasmin. Plasmin then comes to those fibrin monomers and starts to cut them up into little pieces, if you will, and forms these fibrin degradation products, which is something that we will measure clinically as reflective in the D-dimer. So D-dimer is a lab that we measure from a blood sample that helps us to understand how much of these FDPs or fibrin degradation products that are kind of being produced. And if that number is really high, then we know that the body is doing something and has a large clot burden that it's having to try to break down, okay? And so that's why we use it as a measurement, because we all will make some. So normally, remember, there's always this balance between making clots and breaking them down. So we do form fibrin degradation products normally in the normal physiologic processes of the body. You need that, you want that. What we don't want is to miss something where the clot burden is so big, where that number is really high, and we haven't thought, where is this clot at and why is it happening, okay? So like again, DVT, PE, STEMI, we'll see those go up. Aortic dissection, you can see the D-dimer fibrin degradation products going up because the body is trying to balance it. Now, so thrombin blocks the effect of plasmin by upregulating TAFI, okay? So it turns on itself, it stabilizes the fibrin monomers that it produces, and then it protects them by preventing the body from being able to break it down. And that's the inhibition of fibrinolysis. Now, I told you that the king, while it likes itself, says, hey, too much of any good thing can be bad. And that's where the upregulation of protein or production of protein C and also S. Okay, so I've only listed C here, but it's also including S, but C seems to play the bigger part. That is the negatory or inhibitory process that thrombin uses to regulate itself. So when you look at here, you see that there's this feedback on the factor 5A and 8A that stops them, it blocks them. So protein C basically inhibits those cofactors. So therefore, the rest of the coagulation cascade cannot happen. And that's why you see the dotted arrows. It stops it. So there's this production, and then there's this balance of slowing it down and stopping it. Now, imagine a hypercoagulable disorder called factor V Leiden. Well, what is that? It's also known as and called activated protein C resistance. Well, if I have protein C and it's trying to inhibit factor V, but factor V says, you can't touch me, I don't see you, I'm still going to do what I want to do. I am resistant to your inhibition. I will therefore allow this coagulation cascade to propagate. So therefore, I am more likely favoring clot formation. And factor V Leiden, or also known as activated protein C resistance, is a hypercoagulable disorder that is genetically influenced. There's nothing you can do to make it go away. But that's one of the reasons why we have to provide patients with sometimes chronic anticoagulation, especially if they're in certain environments where they're not going to move, like in a surgical procedure or during pregnancy, something like that, where their risk of forming clots is higher. And you add that confounder and you tip the scale. Well, there's also a hypercoagulable disorder that is related to thrombin's own production. And that's GP2210A mutation, where it makes and produces higher concentrations of thrombin just at baseline. Well, you're seeing all that thrombin does to facilitate its production of fibrin monomers. So if you make more of it just naturally, you can imagine that you're going to make more clot. And that is another hypercoagulable disorder. Okay. Now, we do have other endogenous mediators that help regulate this other than protein C and S. We have the lytics that help break down clot, but we have something that helps to slow down the coagulation cascade as well. It's called antithrombin. Well, antithrombin. Well, antithrombin, which is a molecule that people normally produce, is a natural or endogenous anticoagulant. So it will bind to thrombin and prevent it from functioning. It just doesn't do it very well. It's a very weak inhibitor. It's a very weak anticoagulant that's endogenously produced. However, if you give it with heparin or low molecular weight heparin, or even the factor 10A inhibitor that's parenterally administered known as fondaparinux, the binding of those molecules, those drug molecules, to antithrombin changes the shape and the binding affinity of antithrombin, and it more now readily inhibits factor 2A thrombin, but also some degree of 10. Okay? And so it can function as an anticoagulant in the presence of a heparin molecule. Now, somebody can also be deficient in antithrombin. You just don't make it very well, or you don't make enough of it. Well, if it's a natural and endogenous anticoagulant, when it's present, even if it's weak, but I don't make it, well, then it's not going to help you anticoagulate yourself naturally. Therefore, the scale will tip in favor of clot formation. So those are common hypercoagulable disorders that seem to play a role, and it seems to be correlated going back to thrombin and 10A. Okay, so that was a lot there. Now we need to integrate the last part of thrombin, which is the activation of platelets. And it's through a receptor on the platelet surface. There's a lot of receptors on the platelet surface that turn it on. ADP and other things, but one of them is PAR1, platelet activating receptor 1 and 4. So PAR, which makes sense in its naming, is turned on in part by the presence of thrombin. So obviously platelets want to know they need to show up to the party when other members of the party are there, right? So if you're forming a thrombus, you need to be told that it's time to start making a thrombus at some level. Someone's got to tell you. Well, when thrombin is present, that implies there's some active injury or bleeding and the platelet needs to help out. Now, the amount of platelets present in that thrombus formation differs if it's a venous thrombosis or an arterial thrombosis, okay? And I'll summarize those here in just a second in a table. But it's important to recognize that. Okay, guys, that's a lot. But you see, wow, thrombin is huge, huge. Carries a big an amount of weight, role in the overall coagulation cascade, lots of influence, but it's also the target of a lot of drug therapy. So that's that clinical integration piece that I'm wanting to continue to weave into the normal physiology that leads you to the pathophysiology that helps you to understand how we treat it and why we see it. Now let's dive a little bit more into these types of thrombosis that we've been talking about. I've mentioned venous and arterial. Let's break that down a little bit easier for our minds and our eyes to digest, okay? So you know in the vasculature, there's an arterial side that carries oxygenated blood to the tissue, and then it hits the capillary system. We diffuse those gases, and we get the CO2 and lactate and all that stuff, and then we carry it in the venous system back to the heart so that the heart can kick it back out to the lung and get rid of the CO2 and get reoxygenated. So the arterial and venous system are two different vascular systems, if you will. Drug therapy for treating like blood pressure largely addresses that arterial side, but it can also address the venous side and the capacitance of the venous system. Okay? Venous system is very important into things like preload and such that are affecting hemodynamics in the heart. We also have diuretics that influence that preload or the venous capacitance system. So the venous system is important, but it's also a low pressure system. The flow through it is not as fast or under the same degree of pressure as the arterial system that's being pushed through by that heart, okay? So anything that decreases the flow through those systems influences the type of composition of the thrombus. So you can see here that we have some characteristics over here on the left side. Okay, there it is. You see we have characteristics over here. We have what is the initiating factor, the description of the primary composition of the thrombus, and then the end result. Well, the end result is the same. It's just what does that thrombus look like and what triggered it, okay? So on the arterial side, it's usually associated with some vascular injury or plaque rupture. So atherosclerotic disease, it forms that fibrous cap, gets weak, it's highly inflamed, it pops. So you have vascular injury with inflammation. Man, that turns on platelets like crazy. So when you think about conditions like STEMI, ST segment elevation MI, that is an arterial problem. And guess what? What's the first one of the drugs that we're going to give those patients? Aspirin, which is an antiplatelet drug. We're going to potentially bolus them with a ADP or inhibitor like clopidogrel, prasugrel, ticagrelor, and we're going to stop that platelet aggregation because it's the primary problem in that artery of the coronary vessel. That does not mean that we ignore the coagulation cascade, because don't we also administer heparin or low molecular weight heparin in acute coronary syndrome or MI? Yes. Both systems, both sides that are contributing to thrombus are important. The coagulation cascade and the platelet aggregation portion are both key. So arterial thrombosis are primarily platelet in their composition, but there's still fiber monomers and there are still red blood cells. Moving on to the venous side, venous thrombosis, again, it's vascular injury, but it's usually to alter blood flow. So when you think about DVTs or atrial fibrillation, where you have fibrillating atrium that are not moving that blood through the chamber of the heart into the ventricle to be moved, it starts to pool there. Or you've just gotten out of surgery and you don't want to move or stand up, so you're not contracting those leg muscles, and the blood is stasis, like in there. That's that Verkuyle's triad where it just sits there and the clotting factors start to come together and like hold hands and slow down, and they throw a party. And in throwing that party, they form a clot. And then all of a sudden that clot can break loose, whether it's in the atrium of the heart or in the vasculature of the leg, and it can move to a different position. So like in atrial fibrillation, we get concerned about cardioembolic stroke, because it can leave that left atrium, go down to the left ventricle, kick it out to go to our brain, into other organs as well. So that's why we give, it's a venous type of thrombosis, DVT, deep vein thrombosis. Well, what's the primary drug therapy that we use in treating those conditions? Anticoagulants, because it's primarily made up of fibrin monomers from the coagulation cascade. We also see that there's red blood cells. Now, does that mean that there's no platelets? No, there are platelets there. It's just not the primary. So can you use aspirin to treat against cardioembolic strokes and AFib or DVTs? Yes. Is it as effective? No. And it's not as effective because of that. So that makes sense. It helps you to understand why you pick certain drug classes for certain types of diseases, because you understand the normal composition of that thrombus in its context and its milieu of the vasculature. At the end of the day, they both can cause total vessel occlusion and or emboli and block blood flow. So a very large DVT that leaves the leg can go all the way up into the right atrium, down into the right ventricle, and out into the pulmonary artery, and be so big that it causes a saddle embolus that occludes the pulmonary artery very early on, and everything distal to that loses its blood flow, which means the left side of the heart's not going to get the return, and you're not going to perfuse the brain. So you go into cardiac arrest, and it's usually pulseless electrical activity because you have no forward flow volume. And if you don't open up that pulmonary artery with the thrombolytic, that patient is going to die. So it matters that you understand why a particular type of clot is present and what you need to use to treat it. So in acute versus chronic and prevention matters what you use. Okay. Now let's finish off by doing the clinical integration even a little bit further. So I've been talking a little bit about hypercoagulable disorders. I don't want to dismiss the bleeding disorders because they're just as equally important. You can have platelets that are dysfunctional. They don't work like they're supposed to. You can have deficiencies in clotting factors and they're not helping you to form a clot. You can bleed. So we give back those clotting factors. Or we do something to the platelet to turn it on because we need to. Or maybe they need platelets, right? It just depends on what the problem is. So we've provided you with two, for those of you who have access to the notes associated with this particular review, there are two tables, one that summarizes those that favor formation of clots or thrombosis, and then there's a table that summarizes key conditions. I'm not saying it's the full comprehensive of every disease known to man, but the most common ones that would cause bleeding. So this one is related to those coagulation defects that would facilitate a thrombus formation. Now, I've already mentioned this one here. This is factor V Leiden, which I mentioned is also known as activated protein C resistance. So what you see on this side over on the far left are all of the various individual coagulation defects or things going on in the environment that favor the coagulation cascade being propagated. You can see what type of thrombosis is favored with that particular condition. They're not all venous. Some of them are arterial. So look at hyperhomocystinemia. You see that it can form some arterial thrombosis. Same thing with antiphospholipid syndrome that we sometimes see in lupus patients. They can be arterial and venous. So that visual helps you to understand that it's not just all one or other. It has to do with where that problem is in the vasculature. And hyperhomocystinemia tends to be primarily a little bit more in the arterial side. Okay. Now, this is just helping you to understand the prevalence. You can see that many of these diseases are not significant. I mean, some of them do contribute more than, and we see them a lot. That's why we're talking about them. But some of them are, low in incidence. It's not in prevalence. It's not going to be a major player like antithrombin 3 deficiency. I've had a couple cases in my career. I don't see them all the time. Okay. But if I give a medication that's supposed to cause an anticoagulation effect and I'm supposed to see a change in the PTT and I don't, and I know the patient got the medicine and it's not going on the floor, then I got to question the mechanism of action. Why is this drug not working if I'm giving it at appropriate doses? It may be because they don't have the antithrombin to bind to the drug to then exert the effect. So that's where it helps you to understand and recognize, maybe even diagnose somebody with a problem. So then I put at the end some of the treatments that we would give consideration for that particular. So it's a nice summary table for those of you wanting to study, prepare for your boards, your classwork, or even just real-world clinical practice. It's very helpful, especially if you do take care of patients with more hematologic conditions. So the first one you saw was factor V Leiden. Again, it tends to be more of a venous system problem, venous thrombosis, because it's a coagulation cascade problem, factor V in particular. Remember, it's not responding to that inhibition of protein C that was upregulated and turned on by thrombin itself. The next one is that prothrombin 2210A mutation that I talked about. Well, you're going to make a lot more thrombin. Well, that's a coagulation cascade problem, typically more like a venous thrombosis. Okay, so you're going to give anticoagulants to those patients. Antithrombin deficiency. Okay, it used to be called antithrombin 3 in the literature. Sometimes you might see that. But antithrombin and antithrombin 3 are the same thing, but the more current terminology is antithrombin deficiency. Again, it's not going to have that natural endogenous anticoagulant effect. So it's going to favor the coagulation cascade and be more of a venous thrombosis. Protein CNS deficiency. Remember, protein CNS are going to be the negative inhibition on the coagulation cascade's propagation. So it slows it down when it's present and functional. But if you're deficient, it isn't going to turn it off. So you're going to favor clot production if it's not around or it's not working right. And those patients are also going to, need treatment. And there are some plasma transfusions that you can give in those situations, right? But they're at higher risk for forming clots, especially like if you bolus somebody with warfarin or something. You can see that with that and factor V Leiden. Hyperhomocystinemia can occur in vitamin deficiencies in particular. So the B complex vitamins are one of the treatments that can help lower it. There are drugs that are known to increase it. I don't have time to go into all those right now, but there are some that can do that. Antiphospholipid antibody or syndrome is a genetic, again, problem. It can occur both on the arterial venous side, as you can see there. But again, these patients, what they form are these antibodies that bind to phospholipids in the membranes of the vasculature and irritate them, and it triggers them. So you can trigger that extrinsic pathway and intrinsic pathway to favor the coagulation cascade. And that's why anticoagulants are historically more commonly used, but it doesn't mean that aspirin or something or antiplatelet drug won't be added. Now, the last one is the coagulation defects causing bleeding disorders. And again, that's set up in a very similar format, but this is where you're not able to form the clot, whether it's a platelet problem or it's a problem with the coagulation. Now, these are predominantly coagulation defects. There are platelet defects that also can do this, and that's covered in a different topic. East Texas bleeding disorder is located where it says, in East Texas. It's like a pedigree of a family that carries a gene, a very rare gene, but these patients will bleed like crazy from the simplest injury, and they carry antidotes with them, usually tranexamic acid or TXA. They carry it with them, literally like epinephrine, right? Because if they don't stop the bleeding in an acute injury, they may bleed to death. So that's very interesting scenario, but it's very localized to the part of the United States, so that may be limiting to things that people are normally used to seeing unless you go to that area. So they have problems with factor V, but also TAFI alpha in particular, and so they are more likely to favor the cascade towards bleeding. This is where our hemophilia is. So you can see the clotting factors that are defective. So you have hemophilia A, which is factor 8. Remember, it was one of those cofactors. And then hemophilia B, which is your factor 9. And so you get clotting factors from fresh frozen plasma and cryoprecipitate, and those things like that can help replace some of those things. Hemophilia A, you have DDAVP that can increase the release of those. Same thing within von Willebrand's factor. The von Willebrand's factor is also influenced by that. It seems to be connected with factor 8. So, these are important to recognize these and understand them, that those are real diseases that translate in the reason why we administer certain medications to influence that coagulation cascade. I've made comments about the coagulation cascade and the treatment interventions that we sometimes use, especially those that are going to be therapeutically interrupting it to prevent a clot from continuing to propagate forward. And this is a table that just summarizes when we cover the drug classes in other lectures and content, the types of anticoagulants that are out there. So we have vitamin K antagonists, which is historically known as, there's only one in that class, and that's warfarin. We have the heparin molecules, which can make up multiple subclasses. So we have unfractionated heparin, low molecular weight heparin, and then the factor 10A inhibitor known as fondaparinux, which is the parenterally administered. All of those three subclasses carry or have the pentasaccharide sequence that binds to antithrombin. What makes them different is their ability to inhibit factor 10A and 2A, and to what degree. So for example, fondaparinux is a direct 10A or factor 10A inhibitor. All it inhibits is the 10A. Whereas heparin and low molecular weight heparin inhibit both 10A and 2A. They just do it at different ratios, and it's based on the molecular weight. And then you have oral direct 10A or factor 10A inhibitors, and those make up some of the other, with the other oral agents, something called the DOACs, the direct oral anticoagulant drugs that are available that we can use in the acute, but also in the chronic care setting, like apixaban, edoxaban, rivaroxaban in particular. And then lastly, we have our direct thrombin inhibitors that directly inhibit thrombin, don't need antithrombin to work, they just directly take it out. That is like your argatroban, bivalirudin. We do have an oral agent that also contributes to the DOACs, known as dabigatran, okay, that people can use. So that just helps you to see that this stuff is relevant. Understanding and learning the normal helps you to connect the pathophys of a disease, but also the interventions. So I just wanted to hit those as high points. So in summary, we talked about the coagulation cascade, the normal. We integrated it with the platelets. We did not obviously get into all the platelet disorders in this particular review, but there are another set of platelet disorders to integrate. But remember, the two systems are both contributing to clot formation, and all clots have fibrin monomers, red blood cells, and platelets. It's just their composition does vary by their location and the underlying etiology triggering that coagulation cascade. So there's different types of thrombosis. There's the venous and arterial. Remember, venous is going to have more of the fibrin monomers and red blood cells, small amount of platelets, whereas arterial are going to have more platelets and less fibrin monomers and red blood cells. So the drug classes that we use to intervene then should make sense because they're targeting the primary composition of that thrombosis or thrombus that's there. And then we talked a little bit about the clinical integration of scenarios to include even disease states and scenarios that manifest in like miscarriages. And we talked about hypercoagulable disorders and bleeding disorders where you could see some of those clotting factors and when they're deficient or defective, how they can cause a problem. And then how are we going to fix it? You know, how do we replace it? So hopefully that made sense and you found it clinically relevant and something that you can apply for your coursework, training, and more importantly, the patients you serve. Take care.